Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended. And today we are dealing with this dense, brown, hard, hypermature nucleus hiding behind this white coat. And let's see how the surgery goes ahead. So I have planned to do a temporal SICS under subtenon anesthesia in this 78-year-old lady. So now a pocket is being made wherein this cannula is inserted and at least 1.5 to 2 ml of lignocaine is injected. Now a gentle mild cautery is done to cauterize the bleeders. Now making a groove at around 1.5 mm in length, and with the help of this crescent blade a groove is made. Now this groove can be held nicely with the help of this limbs forceps, and we can stabilize the globe easily. At least 7 to 8 mm of incision is made and half thickness is taken, and this crescent blade is used to make the tunnel. So gently with the swiping motion, scleral tunnel is created and then the tunnel is completed while wiping, going in the cornea and then swiping it out. Now the entry with the help of this 2.8 mm steel keratome. Now the capsule is strained underneath the air bubble. After waiting for 15 seconds, the dye is washed out and a 1.8% sodium hyaluronate is injected and the AC is stabilized. So here I am planning to do a mini rhexis first, though it's not mandatory in these hypermature cataracts, but still I'll not take any risk as she is uniocular and this is the only eye with which she has to see. So I am taking help of this micro forceps to complete this mini rhexis. So that's it. Now with the help of this Simcoe cannula, all the liquefied cortex is washed out. And now the real hard brown nucleus is visible. So now this rhexis has extended. So I've stopped washing. It's mostly extended due to the stretching force of the Simcoe cannula. So I should have actually made a larger mini rhexis, but it's okay. So now I'm trying to extend this extended rhexis and complete it into a continuous capsulorhexis. My aim is to create at least 5.5 to 6 mm of rhexis so that I can prolapse this huge nucleus out of the bag. This is fairly good, but still I am not satisfied, so I just make a nick and enlarge the rhexis to my desired size. This should work. So now the wound is extended. Always cut while going in. Now holding the groove and cutting the left side of the incision. That's it. With the help of the dialer, now prolapsing the nucleus, wheeling it out of the bag. This huge nucleus comes out easily through that 5.5 to 6 mm of rhexis. Now OVD is injected both on top and behind the IOL to protect the endothelium and the posterior capsule, and with the help of this irrigating wire vectis, this huge nucleus is brought out of the bag easily. And now some extra cortex is burped out of the bag with the help of this OVD. Not much is left to wash. So with the help of the Simcoe cannula, mostly I'm irrigating at the moment. Now carefully removing the cortex. These bags can be pretty flimsy and thin, and the zonules are unpredictable. So while washing, care should be taken not to get hold of the edge of the capsule. Now subincisional cortex is removed while going through the side port. Gives a better access. And that's it. The bag is clean now. Now here I have planned to inject a hydrophilic IOL. Now as it is a big incision, there is no need to load it up in the cartridge. So with the lens holding forceps, I'm first placing the haptics over the iris in the bag. Do not push the leading haptic in the bag, as it will not stay and it will pop out. So now first I'll be dialing the trailing haptic, push it down and in beneath the anterior capsule. Now dial the leading haptic back subincisionally, put some OVD and then again dial it in the bag. So that's it. Now the anterior capsule is nicely covering the optic. So after thoroughly washing the OVD from the bag, we conclude the case. So the take home message is that in these dense, hard brown cataracts, in these elderly patients with compromised cornea, it's always a good choice to do an SICS. And as I always say, the temporal SICS always corrects the against the rule astigmatism, which is usually present in these elderly patients. I hope you like this video. Do like and subscribe to my channel and help it grow. Thanks for watching.